guys, my name's Matt, I'm an F2 and today I'm going to be talking about CT scans for bleeds. There are lots of different types of bleeding that you can pick up on CT, things like acute GI bleeds, renal hemorrhage, post-renal trauma, but today we're going to focus on the most common bleeds that we face with an A&E or on the wards, and that's intracranial bleeds. So we'll start off by going through a case study, then we'll go through the other most common types of intracranial bleeds and have a look at some of the imaging for those, and then we'll finish with a quick quiz question at the end. So you're the F1 in A&E, you picked up the notes for the next patient and you read this on the triage page. So this is an 85-year-old lady with a background of dementia and falls, and she was found on the floor, not sure how long she's been lying there for, but she was brought in by a neighbour who reports that she's slightly more confused than normal. But the patient herself doesn't remember the fall, not sure if she lost consciousness, doesn't remember any preceding symptoms, and basically you don't get much of a history from her at all. So my first thoughts when looking at this are, this is an unwitnessed fall, so we need to try and rule out sinister causes like MI, PE, cardiac arrhythmias. However, looking at her age and her past medical history, it's more likely this is a multifactorial cause, probably an element of poor safety awareness because of the dementia, and also some poor mobility as well. Another aspect I'd be concerned about would be that we don't know how long she's been lying on the floor for, so I'd want to add on a creatine kinase just to rule out rhabdomyolysis. And then lastly, I'm thinking about whether she sustained any injuries from the fall. So you examine her, you don't find any obvious fractures, she's not complaining of significant pain anywhere, you've examined the spine and specifically there's no cervical spine tenderness and she's got full neck range of motion. Neurologically she's got globally slightly reduced power but nothing focal, cranial nerves all seem intact. When you get her to walk she's slightly unsteady but not too bad. And you find that she's got a small bump on the back of her head. It's not significantly bleeding and it's only mildly tender. So our main consideration now is whether we need to get a CT scan of this lady's head to rule out an intracranial bleed. So there are a number of points that from both history and examination that we need to take into consideration before deciding whether someone needs a CT head after a head injury. NICE have a good clear guideline that you can follow that I'd recommend having a look at, and you can just Google NICE CT guidelines head injury and that should be able to find it easily. But from the history we need to be thinking about how old they are, asking whether they've had any loss of consciousness, whether they remember the events that happened just before the fall, whether they've had more than one episode of vomiting. I also quite like to ask whether they've got any headache that's getting gradually worse since the fall, but also asking things about seizures, and then probably most importantly, whether they're on any anticoagulation or whether they've got a clotting disorder that's not been treated. And then from examination, we should be looking for any focal neurological deficit, so weakness on one side or on one limb, any reduced GCS, are they drowsy, are they more confused than normal? Very important to also examine the cervical spine for any tenderness or any reduced range of motion, because if we're suspecting a fracture we'll need to put blocks around their head and add a CT cervical spine on to the protocol. And then also it's important to look for signs of a basal skull fracture. And the signs are demonstrated here, so you've got things like raccoon eyes or panda eyes, whether there's any leaking of CSF from the ears or from the nose. Battle sign is bruising over the mastoids area, whether they've got any bloods behind their eardrum, and then also any obvious signs of a skull fracture, depression, or a bump on the head. So you discuss the case with your reg, and although your lady doesn't have any red flag features, You decide that she needs the CT heads as she's high risk given her age, the fact she can't remember the fall, and so you can't quite be confident that she hasn't had loss of consciousness. Okay, so I'm going to scroll down from the top of the head down to the base of the skull slowly once, and I want you to look at the images and see if you can figure out where the abnormalities are, and then we'll go back through the images and I'll point them out to you. Okay, so start from the top, working our way down. To the base of the skull. So the most important things to note from this scan, as we go down from the top down to the base of the skull, first of all is this left hyperdense abnormality, which we can just see here, that follows the contours of the skull, and this represents a left frontal subdural hematoma. We've also got an overlying extracranial hematoma. As we come down further towards the base of the skull, we see another smaller subdural hematoma in the left anterior temporal fossa, as well as a slightly more complicated lesion here. This is a right temporal lobe hemorrhagic contusion with a sulcal subarachnoid blood and also a thin subdural hematoma as well. So we'll come all the way down. So those are the main abnormalities. Other important aspects to note when looking at CT heads after a brain injury is whether there's any skull fracture. So there's a separate bone window that we can look at specifically for this, and also looking for signs of compression of the brain. So if there's any shift of the midline, so this line here might be slightly pushed over here if there's any compression, and also looking for cerebral herniation, which is a life-threatening sign. So important to pick up. Just wanted to mention that this is actually a CT scan of a relatively young patient. For elderly patients, especially patients with dementia, tend to have a bit more of a CSF-filled gap in between the brain and the skull. And this gap means that they can often tolerate smaller intracranial bleeds quite well. So we'd want to refer our patient to the neurosurgeons giving her subdural hemorrhage. However, given her lack of neurological signs and the fact that there's no midline shift or herniation, they'd most likely advise to manage locally. And this would involve correcting any coagulation abnormalities, performing regular neuro-obs, and rescanning and rediscussing if there was any deterioration. Other intracranial bleeds that you'll be expected to know about are extradural hemorrhages and subarachnoid hemorrhages. This is a scan of an extradural hemorrhage. Working from the top of the skull down, we can see again a hyperdense lesion on the patient's left. Compared to subdural hemorrhages, the bleed has more of a convex shape. Extradural hemorrhages tend to happen more in younger patients with significant head trauma, and the bleeding tends to arise from a torn artery, usually the meningeal artery, and quite often there's an associated skull fracture as well. We can also see some evidence of midline shift on this scan. This is a CT of a subarachnoid hemorrhage. Working from the top down, we can see hyperdense areas in the hemispheric fissures. And as we work our way down, we can see more hyperdense areas in all of the fissures, into the basal cisterns. And so this would indicate the presence of blood, so a subarachnoid hemorrhage. And this can be due to trauma or they can be spontaneous. Most of the spontaneous subarachnoid hemorrhages are due to a ruptured berry aneurysm. These patients tend to be Middle-aged, 40 to 60 years old, and describe a thunderclap headache with photophobia and meningism. With the most common types of intracranial bleed, so time for a quick quiz question. I want you to have a look at the image on the next slide and tell me where you think the bleeding is most likely to be coming from. Is it coming from A, the meningeal artery, B, a berry aneurysm, C, bridging veins, or D, the cerebral artery? Pause the video to give yourself some time to think. The answer is C, bridging veins. This is a subdural hemorrhage with a concave shape and also some midline shift. Subdural hemorrhages are generally caused by a rupture of the bridging veins that cross from the brain into the dura mater. So in summary then, we've covered the most common types of intracranial bleed. We've talked about subdural hemorrhages, which are the most common, extradural hemorrhages, which are generally related to high impact head injuries, and subarachnoid hemorrhages, which can be traumatic, can be spontaneous, but generally present with a sudden onset thunderclap headache. We need to have a low threshold for performing CT heads with head injuries in elderly patients with dementia or patients who are anticoagulated. But there are some good, nice guidelines that we can use to help us make these decisions. I've included a link to the NICE head injury guidelines here, and I've also put the references for the images that I've used at the bottom. Thank you very much for watching. I hope you enjoyed the video.